This lecture is going to focus on the tri, tetra, and unicyclic compounds. These naming derivatives are based on the chemical structure. So the unicyclic compounds have one substituted ring, the tricyclic compounds have 3 substituted rings, and the tetracyclic compounds, of course, have 4 substituted rings. And so that's where these names come from. Unicyclic prototype, really the only one that's used is bupropion. The tricyclic antidepressants, imipramine, amitriptyline, nortriptyline. The tetracyclic antidepressants include mirtazapine, meprodyline, and amoxapine. The tricyclic antidepressants and others in this category have a variable mechanism of action. All of them inhibit the reuptake to some degree of either serotonin or norepinephrine or both. Their affinities are variable, but they also have affinities to other receptors. And here you can see them binding to acetylcholine specific adrenergic neurons. They can also bind to alpha-1 receptors as well as histamine receptors as well. So here you've got an acetylcholinergic nerve terminal. Here you've got a norepinephrine or noradrenergic nerve terminal, and here's your acetylcholine nerve terminal. And each of these 3 nerves is going to secrete its own specific neurotransmitter. Serotonin shown here in blue, norepinephrine shown here in green, and acetylcholine shown here in red. The postsynaptic receptors binding to each of these neurotransmitters is colored in the same kind of format, with the histamine receptor being obviously a different color. So these tricyclic antidepressants really have kind of a mechanistic interaction in all of these different scenarios. And so from a mechanistic standpoint, they basically inhibit the reuptake of each of these neurotransmitters at the individual neurotransmitter level. So they are, in a sense, indirect acting agonists of all 3 neurotransmitters, and they can also directly bind to these receptors down here. And so you can kind of partition the affinities for norepinephrine or serotonin kind of across the continuum of the available tri, tetra, and unicyclic antidepressants. Desipramine and meprodyline have the highest affinity for norepinephrine. Of course, the SSRIs and SNRIs, fluoxetine, citalopram, and so forth, have the highest affinity for serotonin. And the bulk of our TCAs and tetra and tri and unicyclic TCAs kind of fall in this realm of this continuum. So we can kind of compare the TCAs to both SSRIs and SNRIs, at least when we look at their varying affinities for either of these 2 neurotransmitters. So from a pharmacokinetic standpoint, the TCAs have relatively good oral absorption. They do have first pass effects. In some cases, half of the drug gets metabolized and the other half actually goes to the systemic circulation. Of that half that goes to the systemic circulation, a high degree of it gets protein bound, up to 90%. So a relatively very small amount of this drug actually gets into the CNS to produce any type of measurable biological effect. There is hepatic biotransformation of these drugs through the CYP P450 enzyme system. And the half-life is pretty standard. It's about 24 hours for almost all of them. Almost all these drugs are administered once a day. And they're typically dosed at night, because remember we said that there was some histamine blockade, and that's mostly due to the H1 receptor, of course, and that does produce sedation. Individual notes on TCAs. Amitriptyline is usually given at bedtime because it has the highest degree of histamine receptor activity. Desipramine has less affinity for the histamine receptors, so it is less sedating. It also has less muscarinic affinity, so you see kind of less side effects. It's relatively a decent drug. Imipramine, which is related, of course, to desipramine, has some alpha adrenergic, as well as H1 and M1 receptor activity. And then nortriptyline is really the most potent drug out there. It has a more definitive therapeutic window of activity, and it does have less side effects compared to the other drugs that were just mentioned. TCA side effects are numerous. Cardiac effects are the most common, typically orthostatic hypotension. There are anticholinergic effects, including constipation, urinary retention, and in some patients, blurred vision. Antihistamine effects, the most common is associated with sedation and to some degree weight gain. There's a reduction in the seizure threshold, so epileptics would really probably not do well on a TCA. There's dramatic sexual dysfunction, excess sweating or diaphoresis, as well as tremor due to increased concentrations of neurotransmitter across the board. And some patients do actually respond to these drugs quite unfavorably. So there are some important cardiovascular signs that you should be aware of, including fibrillation, hypertension, and in some cases hypotension. But the most commonly associated side effect that's very step 1 relevant is an increased QRS or QT interval. You can see here, you can see the TCA kind of prolonging that interval quite dramatically. So those are the cardiovascular toxicities that you should be aware of. Patients with underlying structural heart disease might not do well on a TCA, and you might want to choose a different drug. The neurological toxicities are quite numerous. Dystonia, myoclonus, hallucinations, agitation, disorientation, confusion, delirium. These are all associated with a side effect profile and a toxic profile that is very commonly encountered with TCAs. Because there are some potent antimuscarinic effects, we can see the hot as a hair, blind as a stone, mad as a hatter, and dry to the bone type phenomena, reminiscent of the anticholinergic toxidrome that we had learned in an earlier case. Let's focus on the tetracyclic compounds. The main tetracyclic antidepressants include mirtazapine, which is shown here, amoxapine, and of course meprodoline. From a mechanistic standpoint, these increase the release of serotonin and norepinephrine. So they're like tricyclic antidepressants with anticholinergic activity, and they also inhibit or antagonize the D2 receptors. So the mechanism of action is actually quite long. So they inhibit the reuptake, of course. They favor the release of these two neurotransmitters, as well as having some anticholinergic and antidopaminergic activity as well. So you can kind of guess what those side effects are going to look like. From a pharmacokinetic standpoint, we can see metabolism through the hepatic P450 enzyme system. The amoxapine compound actually has a relatively shorter half-life compared to the other drugs. Its half-life is 8 hours, so you can expect at least 2 to 3 times daily dosing. Side effects are generally well tolerated. Sedation and weight gain are definitely encountered with the tetracyclic antidepressants. And then with overdose or with excess doses, you can see a well-described QT prolongation. Mirtazapine, from a chemical structure, is tetracyclic partially, but it's not related to the other tetracyclic compounds. Its mechanism of action is also confusing. It's a 5-HT2A antagonist, and remember that's present on the GABAergic interneurons, and then when those neurons are antagonized, of course, GABA will not be released or will not fire. This might lead to an increased signaling on the neurons that are postsynaptic from that, which will result in an increased release of neurotransmitter release from the postsynaptic neuron. Typically, remember, depressed patients often have more 5-HT2A postsynaptic receptors. But moreover, the drug also is an alpha-2 antagonist, so it increases norepinephrine and serotonin release. It's an H1 antagonist, producing sedative effects. And it has low affinity for cholinergic, alpha-1 adrenergic, and dopaminergic receptors. And so, of course, mirtazapine is a very sloppy drug from a pharmacokinetic or pharmacodynamic profile, but clinically very useful. In terms of its pharmacokinetic properties, the relatively minimal drug interactions It's not an inducer or an inhibitor of a CYP enzyme, which is ironic because it has so many mechanisms of action. There are active metabolites that do circulate, and all of these active metabolites are really kind of the reason we have all of these described mechanisms of action. It's obviously coming from different metabolites, different versions of that compound that float around and hit those different receptors. Most common side effects include dry mouth and sedation. Patients do report an increase in appetite, which of course results in weight gain. With overdoses, they're often benign. You can see some cardiac arrhythmias kind of being manifest. Those, of course, would be monitored. Some patients do produce a QT prolongation that can send them to torsades de pointes, and also some tachycardia as well. With the unicyclic antidepressants, the prototype here is bupropion, also known as Wellbutrin with its brand name. And of course, Wellbutrin or bupropion inhibits reuptake of dopamine and norepinephrine, but it has a much higher affinity for dopamine. It doesn't really affect other neurotransmitters, and as far as we can tell, it doesn't have any affinity for postsynaptic receptors. From a kinetic standpoint, it's metabolized through the P450 enzyme system. It's one of the few drugs that can actually inhibit the CYP2D6 enzyme system. And like other members in this category, it has active metabolites that kind of float around and bind to other receptors. Side effects: less sexual dysfunction and weight gain compared to the traditional TCAs and the tetracyclics. But there also is an increased risk of seizure threshold, and that, of course, is related or correlated to dose.